Coming up on Why Should I Trust You? Dr. Mehmet Oz, the head of the Centers for Medicare and Medicaid Services, is our guest today. He oversees the big programs that provide health care to nearly half of all Americans. It makes up a quarter of the country's spending. So in this moment, what does Dr. Oz see as his mission? Along with Vice President JD Vance, Dr. Oz has been tasked with rooting out fraud in the system, while also defending the changes to Medicaid from the One Big Beautiful Act. Dr. Oz sees both as a way to strengthen Medicaid to ensure it will be there for those who truly deserve it. But official nonpartisan government estimates show that when compared with the previous law, the new law will lead hundreds of billions of fewer dollars going into Medicaid and millions of additional Americans becoming uninsured. Dr. Oz insists that we will spend more on Medicaid, not less. We'll ask him about that. But we also want to go deeper. Who deserves to have health care in America? Are there people gaming the system? And finally, what does Dr. Oz, a leading expert on heart surgery, make of this moment we're in, where trust and expertise is falling? Is growing skepticism of experts a healthy thing, or taking us to a troubling place? And ultimately, we ask him, why should America trust him? Let's get started. Hey, welcome everyone. We have a great show today. We're recording in Washington, D.C., just a short distance from the Department of Health and Human Services, here at the Switch and Board Studios, where our guest today, Dr. Mehmet Oz, serves as the head of CMS, the Centers for Medicare and Medicaid Services. He's going to be here today, guys, and he is going to join us in just a little bit. But first, who are we? I'm Brenda Adhikari.
I'm Tom Johnson.
And I'm Dr. Mark Abdumalik.
And the great Maggie Bartlett is in producer mode today. And this, of course, is Why Should I Trust You, a platform that examines the breakdown in trust in public health, in medicine, science, AI. And as always, you can reach us by emailing questions at whyshoulditrustyou.net.
Okay, so as we said, Dr. Oz will be joining us in person here in the studio in just a minute. But first, Tom, help us get to speed on who Dr. Oz is.
All right, Dr. Mehmet Oz. He's the administrator, as we said, of the Centers for Medicare and Medicaid Services, and that's under the Department of Health and Human Services, which, of course, is led by Robert F. Kennedy Jr., and it is a massive job. So he oversees the federal government's role in Medicaid, Medicare, the Children's Health Insurance Program, CHIP, and the ACA Health Marketplace. And those are programs that nearly 170 million Americans depend on. So in total, Dr. Oz oversees approximately $1.7 trillion in healthcare spending. And that's nearly 1/4 of all federal spending.
That's a lot of dollars.
Yeah, let that sink in for a moment. And as we focus on Medicaid today, let's just try and wrap our heads around that program and how impactful that is. Medicaid is, of course, the main program that we have that provides health care to nearly 70 million low-income Americans. So Medicaid works differently than Medicare. Unlike Medicare, Medicaid is a federal-state partnership. States run their program and make many of the day-to-day decisions, but they have to operate within federal rules, and the federal government pays a major share of the bill.
So Medicare is care for the elderly, and Medicaid is aid for the poor, basically.
Correct. That's a good, simple way to think about it. So 1 in 5 Americans are covered by Medicaid, including about half of all children. And while Medicare is, as we said, the federal health insurance program for 65-year-olds and up, Medicaid actually covers 60% of nursing home residents in America, along with 40% of all births. Some other insights. Medicaid covers both urban and rural Americans, as well as blue and red America, including 1 in 4 residents living in rural areas today. So before Obamacare, to qualify for Medicaid, you generally had to fit into certain categories. A child would qualify, a pregnant woman, a parent with a dependent child, or someone with a disability. And you also had to meet strict low-income requirements, so you needed both. But the Affordable Care Act, the ACA, or just Obamacare, expanded who could qualify for Medicaid. The ACA created a new path to coverage. In states that chose to expand Medicaid, most adults under the age of 65 could qualify based primarily on their income alone. So they did not also need to be pregnant, disabled, or caring for a child. The federal government pays most of the cost of this expansion, and 40 states and D.C. have taken advantage of this. And as a result, Medicaid expansion has extended health care coverage to roughly 20 million additional Americans since the ACA was enacted.
Yeah, Tom, and we're going to ask Dr. Oz about that specifically and whether he views that expansion of Medicaid as a good thing or not. But first, it's worth pausing on who Dr. Oz is and was before he became a wildly popular television figure, a political candidate, or now the head of CMS. So Mehmet Oz was born in Cleveland in 1960, the son of Turkish immigrants. His father was a cardiothoracic surgeon, so he followed in his father's footsteps in a way. And Oz said he has always wanted to be a doctor. He did so from the time he was a young child. He went to Harvard, he played football, water polo, then he got a dual degree, an MD degree, and his MBA at the University of Pennsylvania. He then went on to become a very prominent heart surgeon. He was at Columbia, he was a professor of surgery there, and vice chair of Columbia's Department of Surgery. He spent his surgical career in high-stakes medicine. We're talking things like heart transplants, surgery on heart valves, and finding minimally invasive ways to do major heart surgery. In the 90s, he established and would eventually direct Columbia's Cardiovascular Institute and Integrative Medicine program. And then there is Dr. Oz, the surgeon, who stepped out of that operating room and into America's living rooms. And this is the version of him that many Americans know best. Oprah introduced him as a national figure and dubbed him America's doctor. By 2008, before he even had his own show, Time magazine had named him one of the most influential people in the world. In 2009, he launched the famous The Dr. Oz Show that ran for 13 seasons, and he won 9 Daytime Emmy Awards. He remains one of the most recognizable physicians in America, but he did also draw some criticism from parts of the medical community for promoting supplements, alternative therapies, and health claims that his critics say were not backed by strong evidence. Now, he turned to politics, and his show ended as he launched his 2022 campaign for the U.S. Senate in Pennsylvania as the Republican nominee, a race he would end up losing to John Fetterman. So now he is back in government, but he's no longer just explaining healthcare to America. He, like we said, is running a huge part of it. And the question for us is, what does he do with that kind of power and influence?
Okay, so as we said, that was just a brief bio to give everyone some context. And when we come back, we'll be joined by CMS Director Dr. Mehmet Oz. Dr. Oz, welcome to Why Should I Trust You?
Thank you for having me. Why should I trust you? It's a good question.
It's a good name, right?
It is.
So we're going to talk about fraud and we're going to talk about Medicaid. But first, I want to start on something bigger picture. So we are in a moment where we're seeing a major erosion of trust for institutions, but particularly for institutional expertise. I mean, you've got, it's well documented by now that people are trusting their peers with lived experience, sometimes on par with scientists and doctors. Even Secretary Kennedy has said, we should stop trusting the experts, that it isn't a feature of democracy, that it's a feature of totalitarianism and religion. You, Dr. Oz, are a leading heart surgeon. Okay, you're an expert. If I had like a busted cardiothorax,
Right.
You'd be the guy, right? So what do you think about this? Do you think expertise is overrated?
I had an interesting dinner last night with Ken Burns, who had joined me on my show when I was still making the show. And I have a tremendous amount of respect for him because I've watched his documentaries and I like the way he brings voices alive that have been lost to history pages for centuries sometimes. I don't think the challenges that we're facing right now are that dissimilar from what we have experienced in most of known human history. There are always times, isn't it, when Martin Luther's stapled the list of grievances under the church door in Worms. That was a pretty hefty lift. I think what has changed now is we get to actually hear the complaints. I mean, really understand what they are more than historically was evident. If you were fighting some of the battles around healthcare 50 years ago, I mean, we couldn't even get a simple warning about cigarettes out. It just got stifled, and people who knew how the game was played could orchestrate cover-ups that today we would never tolerate. You mentioned Secretary Kennedy, who's, besides being a close friend, I gained tremendous amount of respect for. I've known him for years, but actually working day to day, every single battle we fight, I respect his courage. Much of his life is shaped by the assassination of his uncle, President Kennedy, and his father. And he does believe that the true story of those assassinations has not come out cleanly. And that back in the 60s, you could imagine that being hidden. It's hard to imagine today that something would happen that was of significant import, and we wouldn't all have 50 opinions on it. And some of those opinions would be more accurate than others, but we at least hear them. I think what your podcast does well is allow the question you just asked to be offered, but then, I mean, truly do the hard work of listening. And I would argue the Maha movement at a fundamental, but one word to define what it was. It's curiosity. Now, remember, most people don't hear so well. They're not that curious. Most questions are statements in the skies. That's true of many podcasts. And so you get biased opinions on both sides. You get driven into a loop by the fact you're not asking the right questions. But together with curiosity, you have to have courage to actually share what you learn, even if it's inconvenient. And you have to be compassionate so you can express it in a way that people actually think that they've changed. And what I love about telling some of this through story, rather than just giving you the facts, and we'll do both today, is telling stories, I believe, works better in changing minds because it gives you room to process what I'm saying. If I just bang fact after fact, now you're trying to audit the fact. Is it the right fact? Did he manipulate the fact? There's a classic line we learned in medical school. There's liars, damn liars, and statisticians, right? You can manipulate everything. But if you actually get into the bigger ideas that are governing how we think about the world around us, as you come up with your hypotheses to test my assertions, you start to learn. And I would start off, answer your question, by taking it all back to COVID. I don't think this started 6 months ago with 24 election. COVID was amazingly destructive to our confidence in what learned people told us. Because like all people, learned people have flaws, have arrogance, and are sometimes unwilling to listen. They have common sense, which is not so common.
Here's a story for you.
Take it.
You're back in your OR, in your office. You're doing a consultation.
Mm-hmm.
You have a patient. She comes in. She's got 3 clogged arteries. She's got an aortic valve that's not so hot.
Yep.
And in your expert opinion, she needs surgery. And you know that you can do the surgery that she needs to basically save her life. But she has a different story. She has her lived experience. She has the story of her sister. Surgery didn't go so well for her husband. She's read on the internet. She's, been on social media. And she just doesn't trust that the surgery that you're recommending is good for her. What do you do with that? How does that make you feel with your expertise and what you need to do? Because that's where we find ourselves a lot of times now today is patients really telling doctors like you, they don't really trust what you're saying.
Well, I'm sure you've experienced this as well. I would never operate on a patient who didn't 100% feel committed to going through it with me. And I have faced the scenario you've described, as I'm sure you have. And I don't think it's wise for us to berate people into surgery, to browbeat them into thinking they're foolish for not understanding how so obvious it is that you do your operation. I used to make some of the commercials in New York City for the hospital as a favor, and they came to me once, they said, we have the best devices, the best equipment that's ever been made for heart surgery. Let's do an ad about how cool our equipment is. And I said, I'm not going to make that ad because I don't think anyone picks their hospital because they have the newest fangled equipment. I said, here's the ad I'll make. 1 in 5 patients that we see for consultations in heart surgery because someone else wants to operate on them, we tell them they should not have surgery because a second opinion will change the diagnosis or the therapy 1 in 3 times. Very few people get a second opinion. But what does that tell us? The art form of medicine is malleable. It should be suited for different individuals. One of the most compelling consultations I used to do hundreds and hundreds of heart surgeries a year. Yeah. So you see thousands of patients to do that. And I learned there's a 95-year-old guy who had exactly what you described, exactly what you listed. Arteries that had been hardened that were going to cause a life-ending heart attack, or even more dangerously, he had an aortic valve that was blocked, which means the heart can't pump the blood out. Mm-hmm. Your way of diagnosing that often is sudden death. And so I told him all this is going to happen. I told him he needed surgery. There was no question at all. And he looked at me and he said, no. I said, I'm not being clear to you. No, he said, you're being very clear to me. I'm not being clear with you. Everyone I care about in my life is gone. I lost my wife. I lost my friends. I've even lost children. I'm good. I have had a fantastic run. I'm not depressed. I love everything that I've done in my life. I'm done. I don't need heart surgery. If I got to go, it's not a bad way of going. Well, I mean, what's the
What
right
I'm
answer?
hearing you say there, Doc, is basically at some level, a patient's got to make a decision for themselves, and you, as an expert, even in that moment, can only do so much. I mean, let me broaden it out a little bit, because I'm with you to a certain degree. I actually feel very seen in some of these statistics about, how folks feel a certain way about experts, because I myself have had, my own experiences with doctors and things like that have left me, asking more questions than getting answers. But broadening it out a little bit more systemically, we talk with folks in science and doctors all the time. And I think there's a real fear in this moment that their expertise is, in fact, not only is it like, well, we should listen to many voices, but that it's actively being undermined and undervalued. And I'll just give you one example. And not that this is your purview. I just want to give it as an example. The stuff that's happening with this OMB policy proposal change, which is all just in comment period right now, but it would basically see federal appointees decide which federal grants should get funded over experts, over scientists, but not just scientists, really any federal agencies. Do you worry that the message being delivered out there to folks who are experts is that, okay, it's your time to take a back seat. We want the lived experience and the political folks to now move up to the front of the bus?
You know what I hear? That we need to fight every single day for what we think is right. If I'm going to sloppily say this policy should just continue and not really interrogate it as much as others may feel it should be evaluated, then I don't deserve to win the day. And if I don't step up every single time I'm in front of a large group in my office, which is why I left to come to you with 100 people on Zoom calls and in person, pushing me on all these issues, I'm not doing my job. One of the biggest advantage I had coming into the administration was the president nominated me early. And so that gave me the ability to go recruit people as fast as I could. I went out there and just grabbed everybody that I thought was going to be top tier. And then I told them all that culture is going to eat strategy. If we don't figure out how to get along with each other, then we're not going to be able to act on the things we all agree should be done. And my main job, even right now, is to get the smartest people I can in a room and make sure they don't kill each other.
What do you say, Doc, to those scientists and doctors and just people in a world where what they've been trained to do is to look at evidence, look at data, and do the best they can using those tools to provide for the people? If they're like, I'm feeling like maybe I don't matter so much right now, what would you say to them?
Well, I'll repeat what I said to the the American Medical Association that I spoke to a few months ago. That I think the medical community has lost its mojo. It's not that, we're not being listened to. That might be happening as well. But we did not speak out on issues recently that we should have made noise about. Again, not to pick on COVID all the time, but things happened during COVID that physicians should have said, stop, no mas. That's not right. Doesn't make any sense. What's the 6-month distance, the 6-foot distance rule? Where did that come from? I don't understand some of these decisions you're making about mandates. I'm firmly agreeing we should save lives when we actually know the answers, but you're making rules that seem made up as you go. And so the political expediency in that case actually hurt us. And so there's many things we can do right now to address that. But let's get back to the root basics. If we're not crisp in our thought process and we're not willing to speak up when things are not going ideally, then we don't deserve it. Let's just define what a professional is, because you're asking me basically questions about what does a scientist or as someone who's got the authority of society to be professional do. There's 4 things that define us. The first thing is we protect our client. In our case as doctors, our patient is number 1, always. That's the Hippocratic Oath. Number 2, we stand on the shoulders of the giants who taught us and we advance the field. We're pretty good at that in medicine. Number 3, you police each other. We are terrible at that in medicine. We are not comfortable holding each other accountable. Even when we see people committing malpractice, we don't go after them. We let the medical boards do all the heavy lifting. We don't want to get our hands dirty. That's culturally a problem. We got to stop. But the 4th thing is this a civic responsibility to speak out. We can no longer hide and hope someone else takes care of it. If you don't like what's going on, go fight for what you think should happen. do it legally, do it, obviously without violence, but, make some noise. And I got to say, I went to when I gave the talk, there's probably, 1,000 delegates there. I had no idea what kind of reception I would get, but I knew in my own heart, I felt that our profession that I had so much pride in had let the country down by not speaking up. And they applauded. So I think most doctors would agree with your premise, that we have been willing to get punched around a little bit. Get your mojo back. Stand up and do what's right.
So you don't want to sideline the experts. You want to bring them back in. Is that what you're saying?
100%. Bring them back in, give them good confidence, the courage, the support. Go out there and make noise. And by the way, the experts aren't going to agree with each other, but I'd much rather watch two experts battling it out about whether you should get a vaccine for hepatitis B at birth than people who actually aren't that studious about that specific topic, but have strong emotional feelings about it.
But you think, Doc, maybe the administration could also meet these guys halfway, being like, by saying a phrase like "you shouldn't trust the experts," that sounds absolute. That it's a feature of totalitarianism is a really absolute phrase. Like, is that the message we want to be sending to this group?
The message that I've been sending is we're open for business. I'll give you a concrete example. A lot of debate in America about gender rejecting surgery in children. Not adults. Adults, I think, adults are adults. They can do what they need. I used to have shows on this topic, so I completely get the challenges as an adult with who's uncomfortable with their gender. But for children, should the American people be paying for gender transforming surgery? And so we wrote a white paper with expert groups coming in, and then we convened basically grand rounds with all the medical societies who are pertinently to this topic interested in coming. So the plastic surgeons came, the endocrinologists, the psychiatrists, the American Medical Association, the family practitioners. We had them all come, and then we just spent hours, like you would in grand rounds, just knocking it out there. Like, what does the real data show? And by the time we were done, the plastic surgeons, who I think were going to do it anyway, said, we don't think the evidence is there to warrant gender rejecting surgery in children. We just don't think that our profession should be thinking that's the right way to go without a lot of challenge to that decision. And then the AMA said, we trust the fact that the plastic surgeons know what they're doing, and so we're going to support their decision. Now, the psychiatrists didn't agree. They went off in their own way. So it's not like everyone got together and was kumbaya, but at least they used science, which everyone didn't agree on how to interpret it, to drive a decision that was a major policy shift for these organizations. Now, as the person who's running Medicaid, my part of this equation was to say, are we supposed to use taxpayer dollars to fund these things if it's not a black and white issue? And yeah, we should fight about that. If you really feel strongly that we ought to be paying with taxpayer dollars for procedures that don't seem to be proven, we'll have that debate. But I'd much rather have it out and open. What I felt in the last administration anyway was the decisions were sort of made culturally. There was tremendous pressure not to speak up, just to agree, just to go back to COVID. Should we close schools or not? I remember getting just hammered on this topic. By the way, all I did was look at the data that was already out there. The Europeans weren't closing their schools. This is back in 2020, even early on. The Europeans, the Asians, they weren't closing their schools. They had made the decision that the kids did not seem to be at risk. And so it wasn't irrational to raise the topic. You could not say it on television.
It's something our show looks at a lot, and what I'm observing now is that there is a little bit more of an appetite now to talk about, the last 5 years, the last 6 years, missteps, things like that. So I think, one of the things our show tries to do is also like, look, a lot of these folks were trying to do the best they could, right? And having that grace and empathy, and quite frankly, we say the same things to doctors and researchers and scientists who are very adamant that anyone who has any vaccine hesitation, for instance, is automatically anti-vax. And we try to make the case that we have to have a more nuanced conversation. So I'm with you on we need to have these conversations out in the open. I would just hope that all of us can agree that, painting any one side as being sort of not valuable because of some function that they have, I don't know how much that helps either. You know what I'm saying, Doc? So I just want to put it out there. But so we want to push the conversation forward.
Yeah, I want to ask about one big thing that you're shining a spotlight on, which is fraud in Medicaid. What are you finding?
Let me, at the outset, highlight how much I love this program. And I say that because if you don't truly adore Medicaid and see it as the ultimate payer of last resort, if you don't get a little teary-eyed realizing how many lives we have saved with this beautiful program started 61 years ago next month, then you won't appreciate the passion that our agency has towards this issue. So when Medicaid started, 11 million people were in the program. 1965. It was designed to help folks, as Hubert Humphrey described it so beautifully. And I work in the Humphrey building. And he's a great senator from Minnesota, Democrat, ran for president. Just that all around, everyone who knew him personally, it's a superstar. And he said, and this saying adorns the entryway to our building, it is the moral test of government to take care of those at the dawn of life. Those are the children. Mm-hmm. We cover most children in America are born into a level of poverty that would allow them to have Medicaid coverage, which is a good thing. We have the ability to take care of these kids no matter what their circumstances are. Humphrey then said, we have to take care of those at the twilight of life, the twilight being the seniors, right? It's about to end. He had a great run, but we'll all be there one day, hopefully. And then those living in the shadows, that's the Medicaid population. So when I came into the agency, I knew we had problems with fraud. I did not anticipate this magnitude. I don't think many of us expected that the problem had gotten so bad. A lot of the changes that happened, and practicing medicine in Columbia, which is a Spanish Harlem, we have a large Medicaid population. So you understand how the system works. And it's not perfect. And there's always going to be fraud to a certain extent in any social programs, because you've got, in many cases, unlicensed individuals in unsupervised settings providing soft services. So
it's in blue states, it's
blue
in red
states, everywhere.
It's in Medicare.
It's everywhere. But so I'm not looking for perfection, but because of COVID, there was a purposeful desire by government to say, let's just not police it so much right now. We got enough problems. Let people get on Medicaid and get the care they need. We got a pandemic going on. And then once the pandemic passes, we'll start to get back to where we were, serious about the rules that govern who's on Medicaid, and what can you do to people on Medicaid, what services are you eligible for, et cetera. So this all sort of goes through. And during the Biden administration, the numbers of people on Medicaid went up quite dramatically until the last year that the Biden administration could make rules, which was 1923, for the next year, 24, they had 92 million people on the program. Now, they went through a process of taking 12 million people off Medicaid because they weren't supposed to be on Medicaid. They had coverage somewhere else because the uninsured numbers didn't really change that much. So the Biden administration took 12 million people off Medicaid. But there were structural changes that had happened in the ensuing period that had basically told the world, you can cheat us. You can come to the biggest federal program of all, maybe the biggest in the world, which is the $2 trillion that come through our doors, and you can harpoon that prey and take what you want out of it. So we now see weaponization of this process with foreign governments involved, we believe, certainly foreign multinational organizations defrauding the system, huge problems, red and blue states. And we have twice as many durable medical equipment suppliers in South Florida than McDonald's.
And that's like wheelchairs and
braces and
that's
canes.
a Medicare fraud example.
That's a Medicare, but there's a Medicaid as well, because Medicare and Medicaid will both pay for that. Yeah. We have in New York State, the number one job of all is personal care services. Personal care services is someone's carrying your groceries upstairs for you. It could be one of your kids or your neighbor's kids. That's a Medicaid program. Again, that's twice as many jobs for personal care services in New York than any other job in the state. Same in California, by the way. And then, of course, we have the hospice fraud in California, which is primarily Medicare fraud. And we have hospice is a beautiful program for the end of your life to allow you to die with dignity. And it was created 40 years ago, ran fine. I mean, there wasn't a lot of hospice fraud until probably 2020. And then suddenly we have roughly 6,000 hospices in the country. A third of them are in LA, just Los Angeles, not California, LA. And so that's not possible. Mm-hmm. Not that many people dying in Los Angeles. And so you begin to realize everyone started looking the other way. They just didn't want to have to deal with this uncomfortable reality, which is the social handshake we have with each other, which is we're not going to steal from our most vulnerable people, right? Who does that? All of a sudden, people just didn't seem to care about that. And as more and more money was made from taking advantage of these systems, you started to see a general corruption. Let's take autism as a good example of this. Now, I don't know if you've had personal experience with autism, but it is a challenge to take care of children on the spectrum. And kids come in all different ways into autism. But we have a lot more of autistic cases now than we've historically had. And when people began to realize that, they began to change how they provided autism care, and not always for the better. So as an example, You can take a kid who just graduated high school, put him through a week of training, and then have him provide what's called ABA therapy, supportive care to kids. Well, you can charge, $100 an hour for that and only give the kid $20 an hour. And so now you've got a pretty big spread. Almost all of autism in America right now is controlled by private equity. Now, I'm not against private equity, but if the motivation of the program is to make money, you're going to hire the least experienced person, pay them the smallest amount possible, charge the most. We have kids now in states, red and blue states, who their states are paying hundreds of thousands of dollars a year for therapy on. And the science supporting that approach to care, 40 hours sitting in very tight programming doesn't seem to make sense in a lot of settings.
Let me tell you, Doc, the stories about the hospice fraud and, what you're finding in some of these areas, it makes me infuriated. I mean, the idea that someone could make up people in a hospice, no one's ever dying, and that's how they bill Medicaid or Medicare, I find that very infuriating. Help me understand something. You're you understand these numbers way better than I do. So, we were looking through some CMS data, and it showed that in last year in 2025, that there were $37 billion in improper payments to Medicaid, right? And in the CMS data, it was showing that was primarily as a result of insufficient documentation and, like you said, the COVID era flexibility kind of expiring and clerical error, right? And that was 77% of it was just people kind of screwing up the paperwork, right? I think what I'm trying to understand is, the administration is really going hard on fraud. Why is the administration seemingly not going publicly in the story, like you were talking about stories, going quite as hard on what appears to be, not criminals, but people kind of screwing up the paperwork that is the vast majority of improper payments in the system?
It's a superb question. The reality is in Medicare, we see the numbers because we're paying the bills. And so this year, last fiscal year, we stopped $40 billion going out the door just in Medicare, just because the payments were not being correctly either billed to us or we didn't think they were appropriate. And that's without even really trying. That's 70% more than the prior year, and it's going to be a lot more this year. Medicaid is a very different beast. Medicaid is like pushing on a string. The state decides what programs they're going to offer. They get permission for us at a high level, and then they go do the program, and then they send us a bill. Now, when you point those numbers out, those are the numbers that we get from them without us really auditing them, because we're not going to go through all those little lines and make sure they're done correctly. The state's supposedly doing it right because they're paying a third of the bill. We pay 2/3, the federal government, they pay 1/3. But it turns out that the bills that we have been getting really aren't that accurate. Minnesota was a good example of that. There are 14 programs at high risk in Minnesota. And I do want to tell this because it's a good story to explain why, if you really love these programs, you'll make sure you care about program integrity. They had planned on one of those programs was non-emergency medical transportation, which is basically I pick you up, I take you to the doctor's office. That is a good thing to do. If you cannot get to the doctor's office to get your medications, get your examination, and then you get sicker and go to the hospital, the ER, or die, God forbid, right? We don't want that. So they thought it cost $1 million. I mean, how much money can it cost you to drive across Minneapolis to your doctor's office, right? When it hit over $100 million, 100 times more than they expected, they shut it down. It's gone. If you're in the cold winter of Minnesota trying to get to a doctor's office, there's no point.
Are you saying that right now there really isn't a way of measuring fraud in Medicaid, and also that this improper payments thing, that you're saying the fraud number is likely higher? Because the reason I ask that is because the GAO and even some of these other nonpartisan groups that we've been looking at their work, they're saying that there really isn't a good way of measuring fraud in this country. I mean, do you agree with that?
I agree. It is very hard to measure the amount of fraud because the way the system has always been designed was an honor system. Again, if you're paying part of the bill, why would I second guess? You know, if we're all four of us going to a restaurant for dinner, all right, and we're all going to pay 25% of the tab, and you decide to look at the bill, I'm not going to second guess you. Like, why would you cheat on the bill? You're going to pay a quarter of it anyway. It turns out that's not quite the right way to look at it. Here's why. And I'm not going to make, these accusations. I can't judge motivation, but I can just observe the facts. If you're a governor And you can get more people hired to be personal care service attendants, carrying the groceries up the stairs, helping with chores around the home.
Which you're saying are good things.
Those are good things to do when they're correctly.
Money, right? So someone doesn't get institutionalized.
Exactly.
Right.
If it avoids you from getting institutionalized, that's a good thing.
Okay.
However, if this program is supposed to have, I'm making the number up, 50,000 people, and it's now 500,000 people, which is the number in New York, you start to wonder, did all those people really avoid going to an institution and charging a lot more money to the system? Or is it possible you got lax on the criteria that you were using to allow someone to provide this service to an elderly person? And maybe it's a jobs program. Because remember, that's now 500,000 people, the most common job in the entire state by factor of 2, who now, instead of being unemployed, have jobs. But who's paying for that? The federal government's paying most of the tab because the state only pays a third. So think about this. If you're the governor, maybe it's not a flaw. Maybe it's actually a bit of a feature. So this happens, by the way, in a lot of places. But you're now starting to face the fundamental reality that because of the way the system is designed, it's okay if it's a little cheating. In fact, there's a vernacular. I worked in New York a good part of my adult life. You medicate it. Medicaid means you pass off the bill to the federal government. You find a way of getting it on their tab because that way we don't have to pay for it because we got our own problems.
But that sounds like people gaming a system that the rules aren't maybe being enforced. But that's very different than criminal fraud, right?
Well,
do you agree with that? Because
yes.
when I heard you on Dr. Phil, one of the things that was said is there's an epidemic of fraud in this country. And I guess that's the part of the storytelling, because I'm with you. Storytelling is important here. To me, the epidemic seems like a lot of screwed up paperwork that lets Medicaid money go out the door when it really shouldn't. And to me as a taxpayer, I'll be honest with you, Doc, that makes me just as mad as like the stories of criminals out there.
Just to tack on to that, I think, our show handles trust. I can just feel some of our listeners and viewers saying, all this spotlight on fraud in Medicaid, is it really about rooting out fraud in Medicaid, or is it about softening support for a program in order to defund the program, in order to chisel away at the program? How do you respond to that?
The reason I listed the example of the non-emergency medical transport was because it's what happens to these programs if you don't actually bring them into some type of integrity. They now got rid of a really good program because they couldn't get their arms around it. They burned the whole village down because they had so much of a problem. We don't want that happening with autism care. You don't want to get rid of personal care services. You need that for people to truly keep them out of the institutions that they don't want to go to. We have the same problems in hospice. The people who have been coming to us and asking for help, and our biggest allies are people from the industry who are legitimate providers. The group that opened my eyes to home healthcare fraud were the home healthcare agencies, because in the country, they were watching total spend on home healthcare going up, but they were getting paid less money. All the money was going to a couple states that had decided not to police the system. And I just want to point something out about whether it's fraud or abuse or
waste or clerical error.
So we call it, FWA, fraud, waste, and abuse. That's what we call it just by the shorthand. But they tend to overlap. The Venn diagrams cross, and they tend to start rhyming. And I'll give you a good example. So they go back to New York State, not to pick on them, but
Go Knicks, go Knicks
for sure. Nova Knicks. We're big Villanova.
That's right. There you go. You got a twofer.
3 out of the 5 players and one more that we traded for. In New York, you start seeing examples where the state legislature loosened the rules of what it meant to warrant a personal care aid. So you have very soft metrics like having trouble with complexity management. Well, what does that mean? That's not the exact wording, by the way, but it's basically really unenforceable things. So when I met with the Southern District, which is law enforcement, right? The Department of Justice, FBI, Office of Inspector General. And I say, guys, why are you not getting after these cases? Where are the convictions? They say, how do we enforce that? How do we enforce it when the person doing the service is not a licensed individual? They're not even validated. We don't even know who they are. The person who's getting the service doesn't know what getting it means. It's in a place we can't monitor. It's not like a hernia operation.
How do you deal with the worst? You're describing criminals, right? These are criminals. How do you deal with these criminals, but still keeping the compass in you that's Dr. Oz that made you so good at what you're doing, and not let all of this crackdown really hurt the people? You said you love the Medicaid program. 70 million people are on Medicaid.
Yeah.
how do you not let it hurt the ordinary person? Because that's what people are really worried about. They're worried about everybody hates the fraud. Nobody here is saying let it go.
Pro fraud.
Nobody's pro fraud.
No one's pro fraud.
There may be some pro Spurs listening, but they're not pro fraud. How do you do that without hurting the ordinary person? The people that you used to meet. You said you took care of them.
I think we protect those individuals who are most at risk if we do two things that are really important. The first is send very clear messages to the community that's involved in fraud. This is not a good place to make money. Just leave the business. I know you're not going away too far, but just go defraud somebody else. And we're starting to see evidence that people are exiting because it's not easy money anymore. You can make a fortune defrauding the system, so you stay in it. But once the money goes away, you're a jerk. You're going to just leave and defraud somebody else. The other thing we've got to do is make fairer rules. And this is not just about Medicaid fraud. This is across the board. Weak rules make bad neighbors. And so we have allowed a process to run amok where the rules don't really allow us to tell if what you're doing is right or wrong. Smart states will game the system better than others. We haven't talked about one of the biggest problems we faced when I first came in, which is the provider tax and state-directed payment issue, which I don't know if I don't want to go into too much detail on this, but basically,
no, he's been studying hard on that one.
Yeah, we know.
So you guys talk about that. Nerd out, Dr. Oz. Be the nerd.
Stay tuned. Let's break for commercial.
Let's do it.
So this is basically legalized money laundering. States with hospitals designed programs to be able to pretend they were spending money that they weren't, and allow that extra pretended spend to be sent to the federal government. We would then pay extra money to the state. So there's a federal match. We're supposed to pay, just using the math I gave earlier, roughly we spend 2/3 of the money. You spend 1/3 of the money. It's a good deal.
But isn't that an incentive so we can get more people the care they need?
Yes, that's good. However, with state-directed payments and provider taxes, these can legalize money laundering. Instead of the max being 2/3 me, 1/3 you, now it's let's just make it 3/4 me, 1/4 you, but not for every state, just for your state. So guess what happens next? The states around you start saying, why is the federal government paying 3/4 of the bill for one state, but only 10% less for another state? And then soon every state starts to do the same thing. So the next thing you know, we have a run on the bank. And by that I mean, we have trillions of dollars that's being taken out from the federal government to pay for states. Now, the fact of the matter is, if you're a taxpayer in Florida, Texas, California, New York, or anywhere in between, if the game is being played to steal from the federal government, to take from the federal government to pay for individual states, we don't know if it's going to be equal or not. It's not fair to you. All taxpayers should be treated equally. Why would you tax New Mexico and Mississippi more to pay California, New York, Texas, Florida? Yeah. So that's why the provider tax issue is so critical. And what we did during the Working Families Tax Cut legislation, which I do think will be applauded in the future, is put Medicaid back on very solid ground. We said, no more gaming it. It's not that we don't want to spend more money on Medicaid. It's just how you pay for it has to be different. So that means if you want your state to be able to give more Medicaid benefits, you have to put more money up. The people in your state, your taxpayers, have to ante up more money so that we can pay twice as much to you. You guys put 10 million more up, we'll put 20 million in. Whatever you put up, we'll match it.
But the states can't afford to pay for all these people in the shadows, and that's why we have a federal government.
The federal government borrows money from the states to pay the states. And if all the states don't do it the same, then, and believe me, they don't. Some states are the varsity team. They're really good at this. Other states, they didn't show up at the money laundering fraud class, right? They just didn't go there. I mean, I'll just give you some numbers. You look at what Mississippi and North Dakota and some of these states just did not play the game. Some states, Alaska, I don't think even has a provider tax. Like nothing. Other states massively. By the way, this is not all red and blue either. Yeah. There's a red state that has expanded Medicaid, didn't spend a penny. They took it all down in provider taxes from other states. So if I'm going to, with great largesse, expand Medicaid and I don't have to pay for it, I'm not actually being a good person. Look at California and again, just to pick on this, the state Medicaid program in California pays for free dental and free vision for illegal immigrants in California until last year. Medicare for seniors in America doesn't give you free dental, free vision.
That's the state's prerogative, right?
No, it's not. I'll tell you why. We're paying for it. If the federal government's paying 2/3 of the money, which we were, then you're actually charging me for your largesse. You're giving away a service.
But that's a state program. That's not Medicaid.
It's a state Medicaid program. And until last July, we were paying 2/3 of the bill back to them. And so what the law did was say, You can pay for it if you want. By the way, they stopped the program immediately. As soon as we stopped paying them back for it, they stopped paying for it because, I mean, first of all, it's very difficult to defend it if you're not giving it to your seniors. But also, why should taxpayers in New Mexico have to pay extra taxes to cover California paying for illegal immigrants to get free vision and dental? I'm not talking about babies. Like, you're allowed to have a baby.
Emergencies, right.
Yeah, true emergencies, anyone can get.
Let's zoom out on the new law. So the Congressional Budget Office, as you know, looked at the existing law, looked at the new law as it pertains to Medicaid. And they said over the next 10 years, the federal government under the new law is going to invest $900 billion less in Medicaid. And under the new law versus the existing law, that's going to result in an estimated more than 7 million Americans who will go uninsured. You love Medicaid. You've talked about the people of Medicaid. Are they wrong with those numbers?
Yes, they are wrong. I'll give you two bits of evidence. The first reality is we're not spending less on Medicaid. We're not spending as much as we are going to spend with Medicaid. And by the way, spending $900 billion more on a program, you better be doing something really important with that money. So we're spending $200 billion more.
So you're saying zooming out in 10 years, we'll have spent
$200 billion.
That year we'll spend, but that tracks, right? Costs go up, healthcare costs go up. So 10 years from now, we'll spend $200 billion more. They're saying over the course of each of these years, we were going to spend this, but now we're going to spend $900 billion less on the program.
What they would just speak for the audience. Yeah. So what they claim it was that it would be a total additional expenditure if we had let it stay the way it was of $900 billion more. Now it's only going to be $200 billion more. There's a $700 billion difference in what we're going to spend over 10 years. The growth of Medicaid expenses is going to be equal to that of Medicare. It's not less than Medicare. It's growing at the rate of Medicare. So why would I want to spend more on one program versus another? Are people on Medicaid worth more than people on Medicare? They should be the same.
What about the 7 million there?
Let me go to that.
Yeah,
so
please.
I brought this up earlier, but I'm going to come back to it. So when the Biden administration took 12 million people off Medicaid, the number of uninsured people did not go up by 12 million people. Many of these people had other places to go. What we're seeing in Medicaid and the Affordable Care Act is people have duplicate insurance programs because they're not paying for it. They're not keeping track of it. So a good number of people in Obamacare are zero premium policies, which means you don't pay anything. Now, we look at those policies. There's 20 million people plus in those policies. Historically, until 2020, there were 9 million people. It suddenly went up to over 20 million people. Of those people who have that policy, 40% never use it. They don't charge a penny against it. Like, where are they?
Well, maybe they're just healthy people.
If you look at average commercially insured healthy people, the number of people who do not use their insurance.
They just have it for catastrophic care. They get in a car accident or they end up in the ICU.
Yes, but again, commercially insured people, generally healthy people, they use the insurance programs at least 85% of the time. So if you own insurance, you'll charge one medication against it. The problem we believe that 5 to 6 million people on the ACA don't even know they have insurance.
So,
They're either
Doc,
covered by
ask,
Medicaid or they literally were put on by brokers. We have numbers that will shock you about things that just are impossible. There's no way this person knows they have insurance. No way. And that's in millions of people, not hundreds of thousands of people.
Look, you're giving really compelling stories about individuals out there who are gaming the system, that there's all these inconsistencies with the rules, and it sounds like there's a lot of overhauling that needs to be done. I want you to talk to those people out there right now who are reliant on that clinic in their community that is now closing in anticipation of what they believe is going to be less funding for Medicaid. I mean, it's happened. There's dozens of them around the country. I'm sure you've heard. There is, in the middle of this gulf of, the system is perfect with the system is run by criminals, there's this world of people out there who depend on a system, who maybe make mistakes when they're filling stuff out. 92 to 95% of them are working. This idea that they're all at home watching TV, it just doesn't track with the facts that your own agency has provided. And so if people out there are like, man, we're about to see massive Medicaid cuts, and so we're closing our clinics in advance of that, what do you want to say to those people as the head of the service?
There is zero financial change to Medicaid until 27. So
that's not that far away, Doc.
No, I know, but clinics that are closing now in anticipation of the growth only being the same as Medicare it seems a little bit incongruent to me. I have actually spoken to clinics that have threatened to close, and the story is sort of the following. We've been having problems for a long time. With this or that other additional change, we're really having trouble. If you don't pour money into us, we're going to not be able to stay in business. Well, I don't want anything to close, but we've had 150 hospitals close, usually in rural parts of the country in the last 15 years. Again, that was not related to poor management. In fact, the $50 billion we're investing in the Rural Health Transformation Fund, the largest investment ever by Medicaid in rural America, that covers 60 million Americans, that is not there to pay the bills. That's there to reform the system, to change the way that healthcare is practiced in rural parts of the country. The bigger discussion, and we ought to get into this a little bit, is not
that means you're going to come back, is what you're saying.
Or you're going to stay.
No, I'll stay. But I think it's worth getting into a little bit. Across the board, we are putting more money into the system. It doesn't matter if we put just money, throw it against the wall. If we don't spend that money wisely, we're not going to get the results we all want. What's the most expensive thing we do in medicine? Without question, bad care. Because you pay someone who's not capable to do a bad job, then you pay someone to fix the bad job, you got to pay them extra.
I thought you were going to say the most expensive thing is when we don't cover someone, you miss early signs of a problem.
That's bad
and
care.
They come limping in bad care.
That's bad care.
Right. So why would we ever want to do anything that would reduce the number of people who are covered in this country?
Medicare, which is a beautiful system. By the way, we're not touching it at all, right? 69 million people now on Medicare. Every single person on Medicare gets a free wellness exam every year. Cost nothing, nada. It's all yours, free. Less than half the population takes it. Less than half. And they tell us why they don't go. They don't go because they're healthier than the other group that does go.
They think they're healthier.
Bingo, you know it. We have the claims data. They think they're healthier. They're sicker. They cost us more. We're giving you free stuff and you're not taking it. This is one of the reasons that we're going to have to get serious about AI. And I am well aware of the problems. I keep asking my kids, please, is there ever a movie where AI is the hero? Like even one, right?
No.
It's always some post-apocalyptic, terrible, crumbling.
Robots taking over the world.
Exactly. It's dystopian. It's just never, right? But if you really want to provide the best healthcare possible, you have to meet people where they are. We have technologies, if you want us to use them, that can go to your medical record, if you allow us to, and give you advice about what you might want to do across the gamut. Is that skin lesion really one that you should go to a doctor right now, or can you go in a month? Or a second opinion on whatever the problem you're facing is. Or if you've got a more serious ailment like a cancer, just to give you advice, because your doctor's using AI right now, because there's no way an oncologist can keep up. This stuff moves so quickly. And so I think across the board, primary care is where we should be investing our efforts. So we put more money into federally qualified health clinics, which I adore, and I would put more money into them. And we, as much as I think we can, and
but that's Medicaid.
That's Medicaid.
Yeah.
But FQHCs are interesting because FQHCs, the real question, I've been to a dozen at least more, but I talked to all the big groups of FQHC, federally qualified health clinics. These are where they provide primary care to at least a third of the population. I asked them, do you want more clinics? Or do you want to be integrated better into the system? They want the latter. They have the clinics we need. They're great because they're integrated.
What does it mean to be integrated? Make their systems work better?
I'll give you a good example. If I was running a hospital, I'd put a clinic opposite from my entryway. Because if you don't have a clinic to go to, you got to go to the ER. Not a good way to spend our money. So I would put a clinic near a hospital. We have not allowed hospital boards to influence these community health center boards because there was a desire to keep the community health center focused on the community. You just have to take care of people in your area. And
it's so like you have to have Medicaid to go there, basically.
You have to have Medicaid, but we pay well for Medicaid. And we also pay you for medications through 340B, and we also pay for psychiatric care. We have medically tailored meals. I mean, there's a lot of things taking place in community health centers, and we put a lot of money into them for that reason. And we want them to be the backbone of the system. We are under primary care in America. If you go to European countries, for example, a lot more primary care. We have a lot of specialists. And my son just finished medical school. And Columbia University's medical school is free if you don't have money. It's free. So 80% of the kids who normally would have to be in debt, they're not in debt. The person who put the money in, God bless him, put the money in because he wanted more kids to not have to worry about debt so they should go into primary care. Of the kids who graduated in his class, I do not know a single one that went into primary care because it's a hard life. But we can maybe help it be a better and easier life by allowing AI to help with workflow, agentic AI to deal with patient inflow, organize the chest X-ray for the cough, get the culture done, check the insurance, all that stuff can be
all
done.
The backroom insurance
exactly.
Stuff, yeah.
We're getting rid of prior authorization as fast as we can.
Is that more important than working on fraud?
Oh, of course. No, but it's much more important. The fraud is a massively important problem that will not fix the healthcare system. It's just, we have to do it.
Okay.
That what's going to fix the healthcare system is improving the quality of care. There are many facets to that, but they're the things that I came into this job to do, and the people who join me for the same reason.
All right, penultimate question. We know you're running out of time.
Penultimate.
Do you believe this era that we've been living in, where the push was to expand coverage through the ACA on expanding Medicaid for states that would do this, was that ultimately a good thing or a bad thing?
It was a bad thing because it perverted incentives. When you run a system as complicated as healthcare in America, the more you can align the stakeholders, the better you're going to be. One of the biggest alignments is does the President of the United States, I don't care what party he's in or she's in the President of the United States and the governor, if they're not aligned, they're going to be trying to game each other the whole time. So the addition of these these all the different things that happened during the creation of the Affordable Care Act changed those incentives dramatically. Now, for those able-bodied individuals on Medicaid, you're getting paid 90% of the bill, not 60% or even 50% the way it was. It's 90%.
And that's worse than the 20 million Americans who got health care through this expansion?
I'd want to give them health care insurance, but when the exchanges were created, what the word exchange means what the law was supposed to do, which is an exchange. Money was supposed to come in from the private sector, 50%, and from the public sector, 50%. That's not what happened. The federal government put so much money into these programs, it jacked up the premiums, so the private sector couldn't join anymore. 95% of the ACA is government-funded health insurance. It's just an expansion. And we have lots of small companies, small businesses who've got 20 employees, paying through the nose to get them insurance. We need them to be able to put their employees in the ACA.
But
we need them to be able to give those
the
services.
idea of who's eligible now for Medicaid, right? Because I think fundamentally what you're asking is we've gone now from being like you had to be like pregnant and poor or have a disability or whatever,
right.
and poor, always that.
Yeah.
But the idea of being single and childless and poor, you're saying maybe that shouldn't qualify you for this.
When Medicaid was created, as we started this whole podcast I was talking about, it was a elegant way of dealing with people who were stuck in poverty, living in the shadows, that was supposed to be able to get you into a more flourishing environment, because you didn't come to this planet to sit around. You have agency over your future. You're supposed to go out there and change the world. The point of the program was to help you build a life of abundance for yourself. And so what we're doing with the work requirements, which is what you're alluding to, and maybe it's a good way to complete this, because this is a philosophical issue that's really important to me, and I think many in the government now. If we can get you off of Medicaid and into the workforce, you're going to find that's a much better way of advancing your life and earning the prosperity that you deserve. And so here's the basic rule of thumb, that if you're able-bodied on Medicaid, you must participate in society with at least 20 hours of service. You either work, you volunteer, or you get an education.
20 hours a week.
Yeah.
Sorry, 20 hours a week. I apologize. It's 80 hours a month, 20 hours a week. We don't want you to have to tell us that. We want this to all be done digitally. And most people actually will have that managed for us. We have generated $600 million in savings for the states who use these vendors. We're paying money as well directly into them, and we're giving them a ton of technical assistance. Most states would be much better off if they had a unified data system anyway. But to give you an example. You're at home, you're working 10 hours a week. You're an Uber driver, right? You want to work 10 more hours. So now that we know you drive, we can go to the state employment office, connect you directly, get you a job, or get you educated to drive a bigger rig, or just let you volunteer, drive to a food pantry or something, to do something so you're engaged in life. And then if you keep doing that, you're going to go up and up and up in the economic ladder, so you won't need Medicaid anymore. That's the vision of it. What we don't want to do is experience what has happened in parts of Europe, where you have generational poverty because it fails the basic litmus test of the twin paradox, which is two twins exist. Yeah. One works, one doesn't, but they have the exact same disposable income at the end of the day. It makes no sense to go to work.
Where is the mercy on how difficult it can be to be on Medicaid and to do all these things, right? You're sick, you're poor, you don't have a steady job, the affordability is out there. The issue
and the idea of it being sick and having a chronic disease doesn't always present as being disabled in the same way that we talk to people on our show all the time. In fact, they're concerned. They're actually Trump supporters who are concerned in this situation where they're worried that they have kids who have adult children who rely on Medicaid, who have good days and bad days, and they're really terrified about these work requirements. And how do you assure them that mercy, like Mark is talking about, is going to be there for folks like theirs?
Well, the beautiful part about the program that Dan Brillman has crafted for us, he's been working in this area for his entire life. It was designed to allow you to get a doctor's note. That's the big question mark that's being fought over. Are you allowed to self-attest? Should I trust that when you tell me you can't go to work because you've got a problem, that you're good to go? And I would argue that's not good enough. You should, if you have a chronic illness, have some interaction with the healthcare system. Once a year, you ought to go to the doctor, probably get checked out. Have that person write us a note saying this individual can't work. We're being petitioned. I'll give you two concrete examples by cancer groups and HIV groups, arguing that if you have those diagnoses, you are therefore frail and should not be obliged to work. I don't think most of us think that's true. I mean, if you have medical treatments which have been remarkably successful, and we have opportunities to be able to make you even better over time, I don't think you should just declare yourself as frail and unable to work for the rest of your life. Now, you might not.
There may be periods of time where you can.
Yes, in which case it's fine.
And you'll give them Medicaid then.
Of course you will. And that's all they need. You just help us understand why you're eligible for it. And by the way, this should be done digitally. Your medical records, if you let us use them, should tell us continually that you had a problem. You don't deserve it.
You can recognize that's a leap of faith for people. I mean, we saw what happened in Arkansas in 2018, work requirements, people got bounced out. They were working, or they could have been exempted, but they got screwed up in the computer systems. So you're asking these folks in the worst conditions of chronic health or borderline frailty to sort of get on a computer and certify they went to the doctor. They're worried they're going to get bounced out.
So for the first year, we're proposing that you get a mulligan. So you can self-attest. Now, I don't want that to be continuous, and this is still proposed, but that we believe that there are going to be times when there's issues, and I've made it very clear to the team, and by the way, they're leading as well. They feel the same way as I do about this. We don't want people falling through the cracks, and we're willing to find ways anyway to help fix the system. But we want to create an expectation that quickly we will figure out ways of, again, without you having to touch anything, we can be able to pull the data if you let us, so we can adjudicate that you've actually done what you want to do. The whole purpose, this is the broader vision, take you from Medicaid, where you're able-bodied perhaps, or maybe you're sick, but you're getting better, allow you to get jobs that you like. With those jobs, enter prosperity, become full-time in your employment so you can actually afford an ACA program with subsidies, and then from there get into the commercial health insurance market. That's the goal. If we can get you through that cascade, which is what I think all of us would like to do, we'd be better off. The question, and we'll leave it with this because you'll have more podcasts to do talk about this, is what do the guardrails look like? Assuming you have to have some. Because when you don't have any guardrails, which is what happened during COVID, you end up with a catastrophic risk, which is that you actually make the program itself insolvent. And then you have people fighting about whether it should exist or not. And if you make the difficult decisions now, this program will be here for the rest of our lives, and it'll be able to thrive, which is what it should be able to do for all Americans. God bless you all.
Dr. Oz, thank you for
so
joining
much.
us on Why Should I Trust You?
Do you trust me?
We got into
I know.
We got into a lot of stuff.
And that is Why Should I Trust You? I'm Brenda Adhikari. He is Tom Johnson. He is Dr. Mark Abdulmalik. Producer Maggie Bartlett. On research, Kushi Patel, Isabella Didi. Thank you so much. We'll see you right back here next week.